here. We're always so pleased. He's like our only physician who actually says, what do you want me to do for the fair every year? So we really appreciate that and his participation. So without further ado, Dr. Matthew Bosner and deep vein thrombosis. It's kind of a hot topic this year, isn't it?
Yes, thank you very much, Steph, for inviting me in. This year it was actually very easy to come up with a topic because Naoma of the auxiliary asked me to speak on deep venous thrombosis because it's the diagnosis of the year for the Missouri Auxiliary, Missouri Auxiliary Association. They have a diagnosis that they focus on each year as their focus diagnosis that they discuss with the auxiliaries, yes, they're called, of the state, and they have fund drives, discussions, public awareness talks, and she asked me to discuss this with you. I also gave a brief overview to our terrific auxiliary group a few weeks ago, so that was kind of the warm-up for this talk. So today I'd like to discuss the importance of deep venous thrombosis, which is a clotting disorder of the legs, which can also cause blood clots to go to the lung, which can become a serious disease. And we're really going to talk about prevention. What can we do to make the diagnosis, and what can we do to prevent this? And I'm just at the end going to take a brief few minutes to discuss treatment options. Now, the key concept is that I have a tendency to be what my kids would call long in the tooth. I talk a lot. My talks have a tendency in the past to go on forever. This is going to be a very short talk, about 15 or 20 minutes, and I'm taking the concept from Abraham Lincoln and the Gettysburg Address. His Gettysburg Address was 2 minutes long. When Everett, who was in November of 1863, he gave a 2-hour speech, went on and on and on for hours and hours at Gettysburg. It's a dedication to the Gettysburg Cemetery for the war dead of the Civil War. And Abraham Lincoln got up, gave a 20-line speech, sat down in 2 minutes. Everett got back up and said, I wish I could say what President Lincoln just said in his 20 sentences, because what he said captured the word and the spirit. So it's the strength and brevity. It's not the length of what you say, but it's the content of what you say. So what I'd like to do in a few minutes is discuss the importance of this disease and then open it up for discussion, because that's the most important part of the talk, which is what I can do to relay the information to you, what questions do you have, and leave it open up to what resources we have available here at St. Genevieve County Memorial Hospital to help in the treatment of you and your loved ones, to help prevent the disease, and what we do when you all come into the hospital or when you're referred to other institutions, as we as your medical providers can give information to your other facilities that you might go to for procedures or medical operations and such to help to prevent the problem. I'm going to scoot out a little bit. So can we turn the lights down a little bit?
Oh, sure. Would you mind giving them right next to the, just the back one, I think.
I'd like to start my talk with this slide commonly. This is about 2:30 or 3 o'clock in the morning at Haleakala Volcano in Hawaii and Maui. And we were going up with my family to take a view of the sunrise at Haleakala Volcano. I had to get my son out of bed he was about 10 or 11 years old at that time, and it was essentially impossible to get him out of bed because he was trying to figure out why did we have to get out of bed at 10 o'clock in the morning, at 2 o'clock in the morning. And hopefully at the end of the talk, you'll see when the sun rises at the end of the talk, I think you'll see why, when we shed a little light on the situation, that there is a very important reason to discuss this. And after about 10 minutes, when the sun came up and he realized why we were doing this, he had a great time. He actually led the whole group down the mountain. Now, what a deep venous thrombosis is a blood clot in the vein of generally the lower extremity. Could be the upper extremity, but most commonly the lower extremity or the pelvis. And these blood clots, which you see right here, depicted right here, can cause pain, redness or swelling and discomfort, but they can also break off and travel directly through the blood vessel system, and I'll discuss this, of the body, directly to the heart and through the heart to the lungs and cause a blood clot in the lungs and cause serious discomfort and even death. And it's one of the three most common causes of what we call sudden death in an individual. The three most common causes of sudden death in adults is a heart attack, what we call a pulmonary embolism, which is a blood clot to the lungs, and a aortic dissection, which is a rupture of the main blood vessel of the heart. Those are the three most common causes. And this is a very common cause, a pulmonary embolism, which is a blood clot to the lungs, and it most commonly arises from a blood clot that originates in the lower extremities. Now, I depicted on our chart here a little, and I'm not a very good artist, but we'll see better depictions here. The difference between the arteries and the veins. The arteries are the blood vessels which carry blood away from the body. When your heart pumps, the blood, after it's received oxygen, the heart pumps and the blood goes out to the body to give oxygenated blood to the muscles for energy and to the other organs of the body, your brain, your muscles, your intestines, and all the organs of your system to do work. Now those blood vessels have thick walls because they have to take the pressure and move the blood vessels down your system. And once the blood has, your muscles and your heart, your brain, the tissues in your body have used the oxygen from the blood vessels move to another system of blood vessels called veins. The veins carry the blood back to the body through the heart, go back to the lungs to receive more oxygen. Now those blood vessels called veins are very different. They are thin-walled, a very low-pressure system, and the veins are within the muscles. The way that the veins work is that, as you see, there's valves. So the veins in the leg, for example, when you walk, the veins are milked by the muscles, just like when you're on your farm and you're milking your cow. That's how you get the milk out of the cow into the pail. Just like so when you walk and you move, you're actually milking those veins to carry the blood back up through your veins to your heart. And when you're moving your arms, you're carrying the blood back from the arms through the blood vessel system to your heart. So you're not just relying on the pressure of the heart to push the blood out, you have to have movement. And that's why it's important to notice when people are bed rest after an operation, people have had a cast because they've had a broken leg. People are in a car ride. We'll talk about who's at risk. These are people at risk. People are in a car ride. People drive to Florida or Texas for a vacation. People have a 5 or 8 hour plane ride because they're going to Japan for vacation. Those people who are not moving their legs and they don't wiggle their legs, they get up and move around and walk, or take a break, those people are very high risk for blood clots because the blood is sitting there, it's not moving, and that's because their muscles aren't moving and contracting. And those are patients at risk, and we'll talk about how to prevent that. So that's a very important concept to know, the difference between arteries and veins. The low pressure vein system needs movement of muscles to get the blood back up to the heart, to go to the oxygen, to get oxygen from the lungs, to move the circle, to get the cycle going. So here's a picture, and I brought a little, I always bring, this is the only, I usually bring a lot of little graphics here, but I'll pass this around. So this is what a heart looks like, and this is about the size of an adult heart, the size of a fist. So this would be an example of the veins coming back from the leg. This is where the veins come back from the head and the upper extremities. And you can see as I open up the blood vessels in the heart, as the blood comes in from the lower extremities, the blood comes in from the upper extremities, it mixes in what we call the right ventricle, and then it goes right out this blue vessel called the pulmonary artery to the lungs to get oxygen. Well, if a blood clot comes up from the leg. It just goes directly into this chamber of the right ventricle, and then it can go travel right into the pulmonary artery to the lung, and that can cause a blood clot. So blood clot it's a straight shot right up from the leg, through the heart, out the artery to the veins. So it's a very straight shot and a very serious.
You said going to the right and out to the left.
No, it goes straight. It never gets to the left because it gets lodged in the lungs.
I mean the blood in general.
Yeah, and then the blood comes back. Blood normally then goes through the little blood vessels, and then it comes back to the left side of the heart, and then the heart pumps it out. But if it's a clot, it gets stuck in the lung, and that's what's lung death. That an infarct means death. So you get a lung infarction, and that's what a pulmonary embolism is. It's death of lung tissue. And if enough lung tissue dies, that's what can cause serious lung failure, shortness of breath, even requiring to go on a ventilator, and possibly death. That's why it's one of the 3 most common causes of sudden cardiac death.
And this would be in like this.
That's exactly. The heart, unfortunately, doesn't sit like Valentine's Day. As I tell all my patients, it doesn't sit here. The heart sits under the left breast, rotated backwards. Okay, so it sits like this. The heart is about the size of your fist. So it sits under the left breast. The tip of the heart tips backwards. So this is how the heart would sit in your body, like this. So if you were having surgery, or when we were in medical school, or nursing school, if you were lucky enough in our generation to do a dissection on a cadaver, you would open up in front of the body. This is how the heart looks like. It looks like this, rotated backwards. Yep. It's right here. It's right in the middle of the chest, rotated backwards. It's right up here in the middle. And that's why if you have a stab wound, if somebody gets shot, they get stabbed, this is where you worry about. The heart ends right in the middle of the breastbone. This is the right side of the heart. It ends right in the middle of the breastbone. Over here is all lung. All lung on the right side. The heart ends right in the middle of the breastbone. Now, if you have a large heart from heart failure, it can get enlarged and come to the other side. We're talking about a normal heart. Okay, we can pass that around and we'll have a big question and answer period. So just in summary, this is the circulation system. The circulation system from the artery, the heart beats, and the blood vessel, the heart blood comes out of the aorta. It can go up 20% of the heart circulation goes up to the brain and the upper extremities. 80% goes down to the abdomen, and then the legs. And then after the body uses oxygen, the veins, noted in blue, carry oxygen back up to the heart, and then it goes to the lungs. You breathe, you get new oxygen on those blood cells. It comes back to the heart, and the cycle starts again. Next slide. We have a little video to describe.
Deep vein thrombosis, or DVT, occurs when a blood clot forms in a vein that's deep inside the body. This kind of blood clot is usually in the large veins of the lower leg or thigh, but it can also appear elsewhere. Symptoms can include swelling, pain, tenderness, and warmth or redness of the skin. DVT is serious because a blood clot can travel to the lungs and cause a pulmonary embolism.
So the blood clot forms in the lungs, goes up through the heart to the lungs, causing that blood clot. So that's the information on the background. So this is already known way back in 1858 when a pathologist in Austria by the name of Rudolf Virchow noted the common characteristics of patients with deep venous thrombosis and primarily pulmonary embolism. And the 3 characteristics he noted, these patients had thick blood called hypercoagulability. They had stasis, or slow blood flow. The blood wasn't moving vigorously. And that's another characteristic of patients. And a lot of these patients had vessel injury for some reason. The common patients he saw were patients who were either in an accident, they were shot, patients who were in accidents, they didn't have cars back then, patients who were in accidents on farms, patients who were in accidents, from falling off of carts, patients that had other trauma, okay? So these were the common characteristics of blood clots noted by Virchow, or in his original description, who were a primary risk for deep venous thrombosis and blood clots. Now, to the lungs. Now, these two diseases are not separate diseases. As I've described, they're related. And we call this common group of diseases venous thromboembolic disease, or VTE. Now, they're both, as a general category, for both deep venous thrombosis of deep veins, because they're deep in the muscles. That's why we call it deep venous thrombosis. That generally refers to the legs or the arms, or it could be the pelvis or the body. Deep venous thrombosis, and that's because it's deep in the muscles, so we described why it's called deep. Okay, and that includes both diseases of the legs, and also that venous thromboembolic disease means embolic, means it goes someplace, and they can break up and go to the lungs. So when it goes to the lungs, it's called a pulmonary embolism. Okay, so the group of diseases are under the category of venous thromboembolic disease, but the two main diseases are deep venous thrombosis and pulmonary embolism. Okay, so if you were getting a test, that would be the two diseases under the group of venous thromboembolic disease. Next slide. So there, between the two diseases, there's between 350,000 and almost 1 million patients a year have both diseases. Okay, and the Center for Disease Control, which is the governmental agency which looks at public health in the United States, estimates about just under 1 million patients a year have both of these diseases. And that's more than the number of new cases of breast cancer, prostate cancer, or any other very common disease. So this is a very common situation. And we'll describe why. And it mostly relates to the commonality of deep venous thrombosis after surgery. That's the most common number that boosts this up. And now we're very aggressive in treating prophylactically patients after surgery. We give them medicine to prevent this from happening, and we'll describe how we do that. Next slide. So in any, and you've seen this before when you come to one of my other talks, there's 3 things we do as practitioners. And we have to do this in order to evaluate any disease. We have to make an evaluation based on your risk. Next. Then we have to set your goals of treatment based on your evaluation. Okay, and then we treat. Now we have to go in that order. Okay, that's very important. Okay, we have to evaluate you, we have to talk to you, examine you, do testing, and then we have to say, what is your personal risk and how do we treat you? Because each of you, your goals of treatment is different because it's based on your risk, based on what's happened before. If you've had a previous blood clot, your risk is much higher than the fact that if you haven't had one before. The most important risk factor for someone for a blood clot is the fact that you've already had one. Okay, that's the most important risk factor. As we're going to see in the treatment section, we initially treat for 3 to 6 months. Once you've had a second event, we treat for a lifetime. So taking a history, evaluating the patient is critical. We do blood testing, we do other x-ray testing. So we can't just start treating people because the risks of treatment are high. We're giving medication that has potential side effects. We're doing x-ray tests. It's expensive. Your insurance covers most of it, but it might not cover it. So we're not going to just do tests on everybody. We're not just going to treat everybody we think might have it. So we have to go in this order. We evaluate, we set goals of therapy, and treat. And one thing I've done since I've come here is work with the staff on developing what we call care plans. So when we have patients come into the hospital, in the emergency room or on the floor, that have high risk for certain diseases, we've set up protocols. If we think patients are at high risk for a certain disease, in this case thromboembolic disease, this is what we do. This is the evaluation plan. We do X, Y, and Z. And if they have this result, this is what we do. It's like a tree, an evaluation tree. We come in, they have these symptoms. If this test shows this, then we do this, then we do this, then we do this. And that's the best way to treat you because it's cost effective, it's fast, we're not wasting your time and money, and it gets you treated faster. And it's not just shotgun therapy. We're not doing what we think is best, we're doing what we know is best. And that's what we want to do here at St. Genevieve County Memorial Hospital, is give you the most rapid, fast, effective treatment that's based on your personal situation, because everybody's situation is different. And our team-based care of therapy with the physicians, the providers, the nurses, the respiratory therapists, the technicians, all work together in developing these care plans to work on your individual care. And we're very proud of that here. Next. So as I mentioned, the three common risk factors are stasis or slow blood flow. Who's at risk for slow blood flow? People who are bed rest. Okay, people after surgery. People who are in the hospital for a prolonged medical illness. Let's say you come in the hospital for pneumonia. Let's say you come in the hospital for, you had your gallbladder out. Dr. Charlotte took your gallbladder out. You have heart failure in the hospital for several days. You have a bad intestinal illness. You have gastroenteritis, bad diarrhea. You're just lying in bed because you're so weak you can't go to the bathroom. You've had your knees replaced, both knees replaced. You're in bed for a long time, getting up occasionally for therapy, but you're in bed for more time than you normally are when you're up and moving. So you have extensive bed rest. Those people are at risk. Okay, you've had a cast for a broken leg, or an external fixator for your orthopedic surgery. We talked about prolonged travel, very important. When you go traveling, if you're going on a long car ride or a plane ride, if it's more than an hour and a half, get up and move. If you're on a plane for more than an hour and a half, get up and go to the bathroom. Get up and walk up and down the hall. When you're in your seat, kind of, just wiggle your legs exactly like we're doing. Perfect demonstration. Wiggle your legs around. Stay well hydrated. Very important. I always talk about our St. Genevieve County Memorial Hospital water. And you guys have laughed, because I always talk about this in every talk. But staying well hydrated is very important in all kinds of situations. But staying well hydrated, dehydration is one of the most common precipitating factors for this. So stay well hydrated. If you're on a long car trip, take one of those little coolers of water, or stop at a gas station or 7-Eleven and get yourself something to drink when you pull over to get gas. So if you're taking a long car ride, stop, pull over, get gas, go to the bathroom, fill up with your water, walk around the car a couple times, every hour or two. That should be your time frame, every hour or two. Patients, the second category are patients who are at high risk for thick blood. The two categories are patients who have cancer or malignancy and non-malignant states. Malignant states are primary patients who currently have active cancer, not patients who have cancer in the past, it's patients who have active cancer, mostly what we call the adenocarcinomas, breast cancer, prostate cancer, cancer in the central nervous system. Those are the three big groups of cancers. Other cancers put people at risk, but those are the big cancers that are associated with thickened blood. Active breast cancer, prostate cancer, brain tumors. Those patients, we give what we call prophylaxis. Those patients who have active acute breast cancer in their initiation phase of therapy, we work with Dr. List and his team, and we give them prophylactic treatment, usually for the first year of therapy, okay? And after that, we can cut back. So for the first 6 to 12 months, they get treated because the risk is so high, and definitely for the prostate cancer patients, okay? Other causes of non-malignant diseases, patients who are at high risk, one of the biggest groups are patients who are pregnant, and up to the first 4 to 6 weeks after pregnancy, because of the change in the metabolism of a pregnant woman with the hormone levels going up and down. The other group of patients who are on birth control pills, especially women who have birth control pills who smoke. That's a huge risk factor for blood clots because of the estrogen content. Now we have lower estrogen containing birth control pills, but definitely 10 or 15 years ago, especially 10 years ago, high estrogen birth control pills and smoking were a huge risk factor for blood clots. It's a lot less now, but especially if we have a female who's on birth control pills, and oral contraceptives and smoke, they're a very high risk. So someone comes in and tells us they have cough, chest pain, shortness of breath, leg pain and swelling, and we get that history, that light goes off in our mind, we get blood tests to evaluate it, and if we're at high risk, we get further imaging testing. And then there's some genetic diseases, some abnormalities of the blood clotting system, and patients can get blood clots. And we're not going to go into those, but there are some genetic diseases. And blood vessel injury, trauma. I had several patients, young, 18, 20-year-old kids who were playing hockey, got whacked with a hockey puck. Okay? Patient, a 22-year-old who slid into second base a couple of days later, came in with leg pain, swelling. Okay, these are normal. You wouldn't expect a big blood clot in a 22-year-old, healthy kid who played, baseball at Southeast. Okay, but when you go back and take the history, that's why the evaluation is so important. If you picked him up off the street, you wouldn't expect a 20-year-old to have a big disease like this. But he not only had and he came in with cough. He not only had a DVT, he had a pulmonary embolism, which was really serious. Okay, and especially in a 22-year-old healthy male. I mean, that would not be a high risk factor. A 22-year-old female on birth control pills who smoke, well, that's kind of a medical school textbook case, but not a 22-year-old male baseball player who's in great physical shape. But when you take the history, he had a hard slide into second base, the guy fell on him making the tag, he came limping off a week before, then it started with pain and swelling in his leg, and then he started coughing. That history, until you got that history, all of a sudden it starts falling into place. He was treated for 6 months with anticoagulation, it went away, and he's doing fine. Next slide. So symptoms, the most common symptoms are pain, redness, swelling, tenderness, especially when one side becomes different than the other, so you become your own internal control. We can see if you have pain, redness, and swelling on one leg, but the other leg feels better. So we always look at both sides together. The skin could be warm to the touch, especially if it's red and swelling. Now you have to realize, in some people, especially with larger legs, your leg can get pretty large and not even know it. I mean, someone who has, a lot of adipose tissue in their legs, it may take a decent amount of swelling to really feel it. Some people have aches and pains, so you have to be sensitive to it. You have to be concerned about the diagnosis, and we get blood tests if we're concerned. So not everybody with leg pain has this, and that's when the evaluation is important with your provider. Are you at risk? Did something happen? Did you have a long car ride? And then we get blood tests, and we'll discuss the D-dimer blood test, which is a very sensitive blood test to measure it. If that's abnormal, we go to imaging testing. Next slide, please. Okay, with respect to pulmonary embolism, chest pain, shortness of breath, coughing up blood, lightheadedness, and dizziness, and that becomes because of low oxygen in your blood. Now, this is seen in about maybe 2/3 of patients, okay? About a third of patients don't have these classic symptoms. So you really need an astute clinician, astute emergency room physician to be worried about this, to pick this up. So it's important not to just go on the internet when you start having these symptoms. It's really important to be evaluated. And I know the internet has been a great source of medical education for our patients, but this is where we get very concerned as providers about internet medicine, because a third of pulmonary emboli are missed because patients don't have the classic symptoms. So it's very important, especially if you have risk factors, if you start having these symptoms, you can be seen by a provider, quickly, but definitely within 24 hours of initiation of your symptoms. Next slide. Okay, the other patients we talked about, patients have recent surgery, especially orthopedic, lower extremity orthopedic surgery. Patients have active cancer, especially those cancers I discussed, breast cancer, prostate cancer, CNS cancer, long-standing severe medical illnesses that put you at prolonged bed rest. Next slide. Older patients, overweight patients, because they don't move as much, are at higher risk. Prolonged travel. Next slide. Okay, certain genetic diseases we discussed. If you've had a first-degree relative, if your brothers, sisters, parents, children have had a deep venous thrombosis or pulmonary embolism, that puts you at higher risk. First-degree relatives. brothers, sisters, parents, children. Okay, we don't look at second-degree relatives, only your grandparents or other things. First-degree blood relatives. Next slide. So most cases of deep venous thrombosis can be prevented by a careful discussion with your provider, by us being vigilant and giving preventive therapy when you go into hospital for high-risk procedures. We were very aggressive about giving medication to people for orthopedic surgery. When they come out, they get low-dose blood thinners, which we've shown in many trials prevent by 95+% decrease the risk of blood clots from and after long standing studies of orthopedic surgery, after heart surgery, after prolonged medical illnesses. And this is one of the core measures we look at in our hospital. Every patient, when we have rounds every morning, we say, is this patient on VTE prophylaxis? Every patient in our hospital, we say yes or no. And if no, we have to say why are they not. So this is an incredibly important disease state for us to look at. So every patient in our hospital is evaluated yes or no, are they on VTE prophylaxis? Next slide. Okay, prevention, get up and move. Activity is very important, especially when you're driving. I said it's important to every hour or so to stop. When you're on a plane trip, a train trip, every hour get moving. Stay well hydrated. Support hose are very good. Low tension support hose. You can buy it at Walgreens. You know, I buy these, socks, these high calf socks for $5, and that's what I wear most of the time at work. They're $5 Dr. Schultz socks. They come in multiple colors. You can buy low ones or high ones. They come up to the calf, and they feel good on your legs. They're low tension. They say 10 to 20 millimeters of pressure, and they're called diabetic support socks. It has nothing to do with diabetes. It just gives extra support to your leg. It's a little, high tension legs. And women, you don't have to wear the support, panties that go up and probably feel horrible, I would imagine. I wouldn't know, but that doesn't sound pleasant to me. But just, if you're going on a plane trip, on a long car ride, I would say to wear support hose or, the support stockings, just a little higher tension. That little extra bit of tension on the legs really makes a difference because it'll prevent those veins from expanding and keep them a little bit more collapsed. And like I said, moving your legs, getting up every hour or two, those are common preventive measures, staying well hydrated, that are so important. Next slide. The blood test we get is called the D-dimer. A D-dimer is a blood test that looks at blood clots in the body. It's incredibly sensitive, 90 to 95% sensitive with the new tests that we get. I mean, it's negative predictive value. If it's normal, the chance of you having a blood clot is incredibly low. So we get this in the emergency room. Sometimes there are false positives. In other words, it may be elevated, but you don't have a blood clot. But as a screening test, that's okay. We'll accept that. We rather have a test that is more specific. As a screening test, we want a test that says if it's negative, that means they don't have the disease. That's what's called specificity of a test. If it's sensitive, that means that if it's positive, there's a chance they have it. There may be a false positive. We may do other tests to confirm it, and then we find out you don't have it. But we'd rather err on that side than err on missing it. We're not going to miss it with a test with high specificity or negative predictive value. And that's why this is such a terrific test. There are some false positives. In other words, if it's abnormal, we have to make sure we got these conditions that we look for, say, okay, well, it's positive because of this reason. But it's and this is our screening test, this is our go-to test that we do. And this is what triages out, are we concerned or not? If it's normal, then we really stop there and we look for other causes of your leg pain. Next. Treatment goals are to prevention of your pain in the leg, prevention of a blood clot, to reduce the likelihood of recurrent events, okay, if you've already had one, and to minimize the long-term morbidity and mortality. Now, what do we do for preventive treatment in the hospital? If for some reason you can't take blood thinners, we give you those support stockings. You've probably seen those on you or your loved ones when you're in the hospital. Either those socks, those support stockings, or you might have seen people that have those plastic pumps on. They're like a little machine. They look like a stocking you put on. You put a pump on it, and it pumps pressure up, relaxes, pump and relaxes. So it squeezes and relaxes like you're walking. So it's like pumping your legs, and it squeezes and relaxes, and it moves the blood and relaxes, moves the blood and relaxes. Now the problem with these, to be honest with you, the pneumatic pumps, is that people can get up, especially our older patients, in the middle of the night to go to the bathroom. They have these things on. They can get complicated. They got to make sure they call their nurse to take it off. So these we're kind of getting away from, unless we absolutely have to use some of the pneumatic pumps, because we don't want people getting up and falling. These socks are still socks. The mechanical support socks. These people go to the bathroom. These we're a little concerned about. The mainstay of therapy in the hospital patients are these little shots we give you under your skin. We give you very low dose anticoagulation medicine to keep your blood a little bit on the thin side. And we know that if we do that on thousands of studies in all kinds of conditions, orthopedic patients, heart failure patients, other medical conditions, if we keep your blood a little bit on the thin side, your chance of having a blood clot goes down significantly. Okay, so that's what we do in all our orthopedic patients and almost all of our medical patients who are going to be in the hospital for more than one day. Now, if you do have a blood clot in your leg or in your heart, there's actually pills we could take now. And even if you have these pills work so quickly, you don't even need the shots. There's one pill called Eliquis that you take twice a day, one pill called Xarelto you take once a day. We can even start treating with that even if you know you have a blood clot in your leg or a pulmonary embolism. These medicines work within an hour, so we don't even need to give you the shots. So new medicines on the horizon work greatly and can be treated acutely if we make the diagnosis quickly. So the treatment, if someone does have a blood clot, is the classic treatment is to get the shots for several days and start you on Coumadin. Coumadin is an anticoagulant. It's rat poison. It's been used for years and years and years. The issues with it is that you still have to give the heparin blood thinner for 5 days, because it takes about 5 days to get the steady state, the right amount in your blood. You have to measure blood tests every couple weeks or every couple months. You have interference with other medications you may be taking. And also when you take like antibiotics, the levels may change. So the levels go up and down, and also with some foods that you take. So we measure blood tests. We can see how much is in your system. And if it's too high, we can cut the dose. If it's too low, we go up on the dose. It works well. It's been around for many, many years. The newer agents called direct thrombin inhibitors. Thrombin is one of the blood clotting factors we like because we don't have to measure the levels in your blood so often. It's not affected by antibiotics. It's not affected by other characteristics in your diet. So we like that because we don't have this variability that we see with the warfarin. Right now, it's becoming better. They're a little bit more expensive, but you have to weigh that against coming in for frequent blood tests, about the variation in dosing. Sometimes people have to change their prescription 2 or 3 times in a month because they're on antibiotics or off antibiotics, they're getting blood tests, and there's co-pays with the blood tests, so sometimes you have to balance one with the other. But we're going away from Coumadin as a general rule towards these new agents just because the ease of use is huge. So I think next is the summary slide. So our algorithm or our method of assessment and treatment is, what is your pre-test probability? What's your risk when you come in to see us in the emergency room or in the hospital or in the clinic? Is your risk low, medium, or high? And then if your risk is medium or high, then we get that D-dimer blood test. If you're after the D-dimer blood test, if the risk is still considerable, we're worried, then we get a ultrasound of either the leg or the arm, if we're worried about the leg, and then we make a decision. So the clinical suspicion, as I said, the evaluation, are we worried? Yes. We get a blood test, we're still worried? Yes. Then we get the ultrasound. And the ultrasound will tell us there's a blood clot in there, yes or no, and then we start treatment. If we're worried in the same way of looking at it, if we're worried about a pulmonary embolism, is your risk high? You get the blood test. Is the blood test elevated or high enough to be concerned about? Yes or no? The test we get is a CT scan, a CAT scan of the chest, because that's the best, fastest way of looking at blood clots in the lungs. We call it a CT angiogram. If people can't do that, there's a lung test we can do called a DQ lung scan. And then we treat, as I said, with either heparin or one of these new agents. We have to treat for 3 to 6 months for the first event, and if you have a second event, it's lifelong treatment. That's it. Okay, we can skip that. I pretty much said that. Okay, so the sun's come up. This is actually only about an hour or two after the sun's up, and all of a sudden you go from just seeing the sun and clouds, and all of a sudden the valley opens up. So it doesn't take a lot to go from just seeing a little bit of the sun before sunrise to all of a sudden the valley's clear. Okay, so a little bit of education goes a long way. Okay, so it's important to be open with your provider. Just tell the emergency room physician or your doctors in the hospital when you come in what medicines you're on, what's happened in your history. Have you just gotten off a 10-hour car ride? Have you just gotten back from a long plane ride from Europe or something like that? Have you just gotten off a big train ride? What medicines you're on, those historical factors are so important to us to help work with you as a team-based method for your treatment. Next slide. And this is what I always like to end on. The inferior doctors, who are the doctors who treat the disease once it's already obvious. Okay? The mediocre doctors treat the disease before it's evident. But we want to be the superior doctors. We want to be the doctors who prevent the disease from occurring before it even is shown up. We want to be the preventive doctors. So we want to work with you, seeing are you at risk, give you medications, and you may say, well, why do I need it? Well, you want to do it to prevention. It's like an insurance policy. Okay, you want to do it and never need the insurance. You never want to have the disease. As I tell patients all the time, why do you carry a car insurance? Why do you have car insurance? Why do you have that card in your pocket? Everybody says, of course I have car insurance. I said, what are the odds that you're going to leave here and have a car accident? The odds are incredibly low, but everybody has car insurance. But if you have car insurance and God forbid you have an accident, it could be devastating. Okay, that's why we want to use medications responsibly and medications that are specific for you. What is the best thing for you? And that's what we do here is we individualize care for you and your loved ones and your family members. And that's what we strive to do here in our team-based medical care at St. Genevieve County Memorial Hospital. Just one side note on this, I've been using this slide probably for 20 years. A Chinese physician raised her hand once and said, Dr. Bosner, do you really know the background for this? And of course I didn't. He said the background for this is that the physicians who were caring for the Chinese monarchs, whatever to call back then, if the Chinese leader died, they killed the physician. So he had to be really good. So that's why they had to be good preventive doctors. Because if they died, he was finished too. So they had to be good with those teas and those lotions and potions they used. So they got very good at the combination of teas and preventive medications they used. So thank you very much for your attention, and I'd be happy to answer any questions.
Vitamin E, keep that blood thin.
Vitamin E has not been shown to be preventive for any aspect of cardiac disease from an issue of prevention of blood clotting. It's good as a mild antioxidant, but it's not really preventive.
Is there a vitamin that does prevent?
Well, and a good antioxidant, actually, rapeseed extract is good, and also CoQ10 is good. But it's not really going to be, you're not taking it as an anti-inflammatory for this. What you're taking it for is to help the metabolism of other medications and the metabolism of inflammation to prevent atherosclerosis in your blood vessels. So those vitamins aren't helpful for this. It's important for men over the age of 50, okay, to take a baby aspirin every day. That's important to help cardiovascular risk. For women, if you've had any kind of cardiovascular intervention, if you've had a heart attack, if you've had a stroke, if you've had any kind of a cardiac stent, a bypass, any peripheral vascular surgery, or if you have 3 cardiac risk factors or more, it's beneficial to take an aspirin. In women, It's not been shown to take an aspirin if you haven't had one of those under the age of 50, or before or after the age of 50, because the risk of bleeding is higher in women. But in men, it's been shown to be beneficial. If you have had a cardiac event, if you have had a heart attack, a stroke, you've had a cardiac stent, bypass, peripheral vascular disease, or if you have 3 cardiac risk factors, it's recommended, which is high blood pressure, high cholesterol, diabetes, smoking, central obesity. It's recommended to take an aspirin. Sure. Yes.
Would you be at risk for this disease if you have any varicose veins?
Well, varicose veins, you are at risk, because what varicose veins are is that the veins are dilated and the blood's not moving. So yeah, you are more at risk. That's why one of the treatments of varicose veins is compression hose. Okay, and that's one thing we recommend. Stay well hydrated in compression hose. And what varicose veins are is think about in a bad storm, if a branch falls down in your backyard, it blocks the main creek and the water starts going around into other little tributaries and eventually finds the main vein. That's what a varicose vein is. One of those other little veins gets enlarged in the legs. And what it is there's a tiny little blockage in one of the channels, and the blood is finding other little ways to get around, and those other little capillaries become dilated. Especially if you can see them and if they're raised off the skin, those are significantly enlarged. Those patients, we recommend taking an aspirin every day, wearing compression hose, and if it becomes symptomatic, we recommend seeing a vein specialist. Dr. Krikorian, who's one of my associates here, is an excellent vein disease. I'm not an interventional cardiologist. I'm a diagnostic. I don't stick needles in people. But Dr. Krikorian is an excellent vein specialist. We're actually going to give later in the spring, we're going to be giving a symposium on venous disease. We had one on arterial disease earlier. There's some information you'll probably see in the Herald, and we'll probably have some kind of public service announcement that Steph and I will work on. Dr. Kapoor and I were just talking about this week. We'd like to have a public seminar or evening discussion on this, because he is really an expert on this venous disease and varicose veins. He has some great treatments for that, so I would recommend, we'd be happy to see you for screening, see your primary care provider. I'd be happy to see you, but we usually do the workup and the evaluation, diagnostic work. We work with Dr. Krikorian on the treatment for that, because he's really an expert on that. And I saw my cards here. I'd be happy to see you, and then refer, get the testing, and then we can do the treatment. You can work with your primary care provider.